Hello, everyone. My name is Ray Desatel, and I am the cost measure lead here at CMS, and I'll be going over the 2024 MIPS cost overview. Next slide, please. And here's just a disclaimer noting that, that this was prepared as a tool to assist providers and isn't a legal document. Next slide, please. Okay, so during this overview, I'll start with an introduction, then go over the basics of the cost category, the 2024 updates to the cost category, participation in the cost category, and finally reporting and scoring for cost. And then we'll close with some help and support resources. Next slide, please. Okay, next slide, please. So for introduction, so this presentation will review the participation requirements for the cost performance category for the 2024 performance year. There's also an additional webinar that provides an overview of the MIPS participation requirements across all performance categories, and that is on the QPP webinar library, which is linked in this slide. Next slide, please. Okay, so let's take a look at the MIPS reporting timeline as a whole. For calendar year 2024 performance period, that began on January 1st of 2024 and will end on December 31st of 2024. Early next year, data submission will begin and will open until March 31st of 2025. And then feedback will be available later on in 2025. And then finally, payment adjustments will be applied in calendar year 2026. Next slide, please. Eligible clinicians report measures and data for quality improvement activities and promoting interoperability. However, for cost, there is no reporting requirement. So CMS will collect and calculate data for cost on behalf of eligible clinicians. Performance in all four categories will result in a MIPS final score of 0 to 100 points. Your MIPS final score determines if you receive a negative, neutral, or positive payment adjustment. And again, payment adjustments based on performance during the 2024 performance year will be applied to payments for services starting in January 1st of 2026. Next slide, please. So for the 2024 performance year, there are three MIPS reporting options. There's traditional MIPS, MIPS Value Pathways, or MVPs, and the APM Performance Pathway, or APP. For traditional MIPS, eligible clinicians select quality measures and improvement activities, and then they report the complete promoting interoperability measure set and will be scored on all cost measures for which they meet or exceed the case minimum. For MVPs, eligible clinicians select from the quality measures and activities within their selected MVPs, and then report the complete promoting interoperability measure set, and then they will be scored on every cost measure available within their selected MVP for which they meet or exceed the case minimum. And then finally, for APP, there is a predefined measure set that's available only to MIPS APM participants. Next slide, please. The cost measures are attributed to clinicians according to each measure's specifications. Each cost measure has two specification documents: the Measure Information Form, or MIF, which describes the methodology used to construct the measure, and then the Measure Codes List, which contains service codes and clinical logic used in the methodology. Next slide, please. For the 2024 performance year, the cost category will account for 30% of your MIPS final score. Like quality, the cost performance category has a 12-month reporting period. And for 2024, the performance period is from January 1st, 2024 to December 31st, 2024. As I mentioned, there is also no reporting requirement for the cost performance category, so CMS retrieves all cost data from your administrative claims. And in order to be scored on a cost measure, you or your group must meet or exceed the case minimum for that cost measure. And finally, you or your group can earn up to 1 percentage point for improvement scoring in the cost category for the 2024 performance period. Next slide, please. There are a total of 29 cost measures for the 2024 MIPS performance period. For traditional MIPS, you will be scored on every cost measure for which you meet or exceed the case minimum. If you don't meet the established case minimum for any of the available cost measures in MIPS, the 30% weight for the cost category will be redistributed to another performance category or categories, which is typically quality. For MVPs, each MVP includes a subset of cost measures applicable to the MVP's clinical topic, and you will be scored on every cost measure available within your selected MVP for which you meet or exceed the case minimum. Subgroups are evaluated and scored on cost measures based on their affiliated group, and you cannot be scored on any cost measures in the MVP. And if you cannot be scored on any cost measures in the MVP, the weight will be redistributed to another performance category. And then finally, measures can earn between 1 and 10 achievement points based on performance in comparison to a performance period benchmark. Next slide, please. So as I mentioned, there are 29 total cost measures for the 2024 performance period. This slide goes into details on the 29 cost measures available. So they include the Medicare spending per beneficiary, or MSPB clinician measure, the total per capita cost, or TPCC measure, and then there are 27 episode-based cost measures. Of the 27 episode-based cost measures, 15 are procedural-based, 6 are acute inpatient medical condition-based, 5 are chronic condition-based, and 1 is focused on care provided in the emergency department. And then the slide also documents the case minimums and data sources for the different cost measure types. Next slide, please. So for 2024, CMS added 5 new episode-based cost measures. They are psychoses and related conditions, depression, heart failure, low back pain, and emergency medicine. Next slide, please. Beginning with the 2024 performance period, CMS also removed the simple pneumonia with hospitalization measure from the MIPS program. And finally, we updated the operational list of care episodes and patient condition groups and codes for all the new measure additions, as well as the exclusion of simple pneumonia with hospitalization. Next slide, please. For cost scoring, improvement scoring for the cost performance category will be calculated at the category level without using statistical significance, beginning with the calendar year 2023 performance period. And the maximum cost improvement score of 1 percentage point out of 100 percentage points will be available beginning with the 2023 performance period. The maximum cost improvement score available for the 2022 performance period is 0 percentage points. Next slide, please. On this slide, we have some of the features of cost measures defined. Payment standardization is the process of calculating standardized claim payment amounts that allow for the measurement and analysis of clinician resource use by CMS and researchers. Payments included in MIPS cost measures are payment standardized. And benchmarks are calculated for each cost measure, which are based on the performance year, not a historic baseline. All MIPS eligible clinicians that meet or exceed the case minimum for a measure are included in the same benchmark. Next slide, please. The calculation of claim-based cost measures requires the attribution of episodes or patients to clinicians and groups so that the associated costs can be evaluated through a specific measure. Each measure's attribution methodology is detailed in the Measure Information Form, or MIF. And then finally, risk adjustment. The risk adjustment accounts for differences in patient characteristics, such as clinical risk factors that aren't under the control of reasonable influence of an attributed clinician or group, but that may influence the cost of care provided. Next slide, please. Okay, so now I'll review the 2024 cost measures. Next slide. First up, we have the Medicare Spending Per Beneficiary Clinician Measure, or MSPB clinician. Each MSPB clinician episode assesses Medicare Parts A and B costs incurred by a single patient during the episode window, which is a period of time beginning 3 days before an index admission through 30 days after hospital discharge. Next slide, please. Medical episodes for the MSPB clinician measure are attributed to clinicians in 2 steps. First, the episode is attributed to the TIN that billed at least 30% of the inpatient evaluation and management, or E&M services listed on the Part B physician supplier claims during the inpatient stay. And second, the episode is then attributed to any clinician in the TIN who billed at least one inpatient E&M service. Surgical episodes are attributed to a clinician, so a TIN NPI, who billed any related surgical procedures during the inpatient stay, and to the TIN under which the clinicians billed for the procedure. Next slide, please. Patients are excluded from the MSPB clinician measure if they weren't continuously enrolled in Medicare Parts A and B, or is enrolled in Part C for the entirety of the episode window, or 90-day look-back period before the episode start date. The patient has a primary payer other than Medicare for any time during the episode window or 90-day look-back period prior to the episode start date. The patient's date of birth is missing from data sources. The discharge of the inpatient stay occurred in the last 30 days of the performance period, or if the patient's death occurred during or before the episode. Next slide, please. Episodes are excluded from the MSPB clinician measure if no main clinician is attributed to episode, the index admission didn't occur in a, quote, subsection B hospital paid under the Inpatient Prospective Payment System, or IPPS, or an acute care hospital in Maryland. If the index admission was involved in an acute to acute hospital transfer, or if the claim of the inpatient stay indicated $0 actual or standardized payment. Next slide, please. The MSPB clinician measures case minimum is 35. So that means 35 total MSPB clinician episodes must be attributed to a MIPS eligible clinician or group for the measure to be scored. A clinician participating in MIPS as an individual won't receive an MSPB clinician measure score as an individual clinician if the clinician doesn't bill Medicare for Part B physician supplier services furnished to patients during hospital stays, and therefore doesn't meet the case minimum. Next slide, please. The MSPB clinician measure is risk adjusted to account for patient age, comorbidities, disability status, and ESRD status, among others. And a separate risk adjustment model is estimated for MSPB clinician episodes within each MDC, or major diagnostic category. And the full list is listed on the slide. Next slide, please. And the MSPB clinician measure is calculated by first defining and triggering the population of index admissions associated episodes, then attributing the episodes to a clinician or clinician group. Third, by excluding clinically unrelated services and calculating episodes observed costs, and then excluding any episodes, then calculating expected episode costs through risk adjustment, and then finally calculating the average costs per episode. Next slide, please. Next, we have the total per capita cost measure, or the TPCC, which measures the overall cost of care delivered to a patient with a focus on the primary care received from their providers. The first 4 steps to calculate TPCC are, first, to identify candidate events based on the occurrence of certain primary care or outpatient services that indicate the start of a primary care type relationship. Second, applying service category and specialty exclusions to only include specialties and clinicians providing primary care type services. Third, constructing risk windows opened by candidate events during which a clinician could reasonably be held responsible for the beneficiary's treatment costs. And then finally, attributing beneficiary months that occurred during a risk window in the performance period to TINs and TIN MPIs. Next slide, please. So patients are excluded from the TPCC measure if they had a primary payer other than Medicare or were enrolled in Part C for any month during the performance year. If they weren't enrolled in Medicare, in both Medicare Parts A and B for every month of a performance year, unless part year enrollment was the result of a new enrollment or death. If they resided outside the United States or its territories during any month of a performance year, if they are covered by the Railroad Retirement Board, if their date of birth is missing from the data sources, and if they died before the start of the performance period. And specialty adjustment is applied to the TPCC measure to account for cost variation across specialties and TINs. The specialty adjustment is performed at the provider level, and clinicians meeting service category exclusions or specialty exclusions aren't included in the measure. Next slide, please. The TPCC measure case minimum is 20 patients. So clinicians and groups will only be scored on the measure if they're attributed many months across at least 20 patients. And with regards to risk adjustment, a TPCC risk score is generated for each beneficiary month using diagnostic data from the 12 months immediately preceding each beneficiary month. Separate risk adjustment models are used for new enrollees, continuing enrollees, and enrollees in long-term institutional settings, and enrollees with ESRD. Next slide, please. So the TPCC measure is calculated for the following steps. So first, you calculate the payment standardized monthly observed costs. Then we calculate the risk scores and risk adjustment monthly cost. Third, we specialty adjust monthly costs. And then finally, we calculate the average TPCC cost per beneficiary. And when calculating the TPCC, the numerator is the sum of the risk-adjusted, payment standardized, and specialty adjusted Medicare Parts A and B cost across all beneficiary months attributed to a TIN or TIN MPI during the measurement period. And the TPCC denominator is the number of beneficiary months attributed to a TIN or TIN MPI during the measurement period. Next slide, please. Okay, so the acute inpatient medical condition, procedural, and care setting episode-based cost measures assess the cost to Medicare for the items and services provided to a patient during an episode of care. These types of cost measures only include items and services related to the episode of care for a clinical condition, procedure, or setting. Next slide, please. For acute inpatient medical episodes, an episode is attributed to clinician groups or TINs that bill at least 30% of the inpatient E&M claim lines during the trigger inpatient stays, and to clinicians or TIN MPIs who bill at least one inpatient E&M claim line under a TIN that meet the 30% threshold. Procedural and care setting or the emergency medicine episodes are attributed to the clinician who bills a trigger code for the episode group. For clinician groups, episodes are attributed by aggregating all episodes attributed to clinicians that bill to that clinician group. Next slide, please. Acute inpatient, procedural, and care setting cost measures are calculated via the following steps. So first we have the trigger, and we define the episode. So episodes are generally defined by the billing codes that trigger an episode, and episodes may be placed into mutually exclusive and exhaustive subgroups for meaningful comparison. Then we attribute episodes to a clinician. Third, we determine episode costs and calculate total observed cost. So for procedural and acute inpatient medical condition episodes, only services that are clinically related to the attributed clinician's role in managing care are included in the episode. And for the emergency medicine care setting episode-based cost measure, clinically unrelated services are removed from the episode. Next, we exclude episodes. So measure specific exclusions remove unique groups of patients from the measure in cases where it may be impractical or unfair to compare the cost of caring for these patients to the cost of caring for the measure's cohort as a whole. Then we calculate expected episode costs through risk adjustment. And then we calculate the average cost per episode. Next slide, please. Okay, so the next few slides list out the 15 procedural episode-based cost measures, the 6 acute inpatient medical condition episode-based cost measures, and the 1 care setting episode-based cost measure for emergency medicine. And so for each of these measures listed in this table, an episode is opened, aka triggered by a certain clinical event, referred to in the table and other documentation as the trigger. An episode window may, but not always, include a period of time before the triggering clinical event, and that's referred to as the pre-trigger period, plus a period of time after the triggering clinical event, and that's referred to as the post-trigger period. And some episode windows begin when the triggering event occurs and doesn't include a pre-trigger period. Therefore, they have a pre-trigger period of 0 days. And the episode window used to calculate each of the episode-based measures is listed in this table. And so we have elective outpatient percutaneous coronary intervention, or PCI, knee arthroplasty, revascularization for lower extremity chronic clinical limb ischemia, routine cataract removal with intraocular lenses, implantation, screening and surveillance of colonoscopy, acute kidney injury requiring new inpatient dialysis. Next slide. Elective primary hip arthroplasty, femoral or inguinal hernia repair, hemodialysis access creation, lumbar spine fusion for degenerative diseases, 1 to 3 levels, lumpectomy, partial mastectomy, and simple mastectomy, and non-emergent coronary artery bypass graft or CABG. Next slide, please. Renal or uteral stone surgical treatment, intracranial hemorrhage or cerebral infraction, STEMI PCI, inpatient chronic obstructive pulmonary disease exacerbation, COPD, lower gastrointestinal hemorrhage, and that's at the group only. Next slide, please. Psychoses and related conditions, melanoma resection, colon and rectal resection, sepsis, and emergency medicine. Next slide, please. So next, we'll talk about the chronic condition episode-based cost measures. So these are attributed to the clinician group that renders services that make up a trigger. A trigger event for chronic condition episode-based measures is identified by the occurrence of 2 claims billed in close proximity by the same clinician group. And both claims must have a diagnosis code indicating the chronic disease captured by the measure. We apply checks to ensure clinician groups are involved in the patient's care. So a clinician within the group has provided care to patients prior to or on the episode start date. And for some measures, there are additional clinician and group level medication prescribing requirements. Next slide, please. Chronic condition cost measures are constructed and calculated via the following steps. First, we identify the patient-clinician care relationship. We identify the total length of care between a patient and a clinician group. And we define the episode. We attribute the episode to the clinician group and clinicians. Then we assign costs to the episode and calculate the episode scaled observed cost. Then we exclude episodes. Then we calculate the scaled expected cost for risk adjustment. And finally, we calculate the average cost per episode. Next slide, please. Chronic condition cost measures have the following exclusions. So they're excluded if the patient has a primary payer other than Medicare for any time overlapping the episode window or 120-day look-back period prior to the episode window. If the patient wasn't enrolled in Medicare Parts A and B for the entirety of the look-back period plus episode window, or was enrolled in Part C for any part of the look-back plus episode window. If the patient wasn't found in the Medicare enrollment database, if the patient's death occurred before the episode end date, if the patient resided outside the United States or its territories during the episode window, if the patient has an episode window shorter than 1 year, and if the patient has extremely low treatment costs. Next slide, please. There are 5 chronic condition episode-based cost measures available in 2024. They are asthma, chronic obstructive pulmonary disease, COPD, depression, diabetes, heart failure, and low back pain. All measures but low back pain have a minimum episode window of 365 days, while low back pain has a minimum episode window of 120 days. And next slide, please. Okay, so finally, I'll go over cost scoring. Next slide, please. So CMS uses administrative claims data to calculate cost measure performance. So again, participants don't have to submit any cost data when reporting MIPS or MVPs. Under traditional MIPS, clinicians are scored on each measure for which they meet or exceed the established case minimum requirements. And for MVPs, each MVP includes cost measures relevant to the MVP's clinical topic or episode of care. CMS will calculate performance exclusively on the cost measures that are included in the selected MVP for which the clinicians meet or exceed the established case minimum, even if additional cost measures outside your selected MVP are available for scoring. And subgroups will be evaluated for and scored on cost measures based on their affiliated group. And then APPs don't measure cost performance. Next slide. For a cost measure to be scored, an individual MIPS eligible clinician or group must meet or exceed the case minimum requirements. If one cost measure can be scored, the measure score will be used to compute the performance category score for cost. If multiple cost measures can be scored, the performance category score is equally weighted average points assigned to the scored measures. And then if no cost measures can be scored, costs will count towards 0% of the MIPS final score, and CMS will reweight the other performance categories. Next slide, please. CMS will assign between 1 to 10 achievement points for each scored measure based on the clinician or clinician's performance compared to the performance year benchmark. And achievement points will depend on which decile range that performance on the measure falls between. Next slide, please. For reweighting, CMS will automatically reweight the cost performance category for MIPS eligible clinicians affected by the EUC policy. If a MIPS eligible clinician is located in an affected area, CMS will assume the clinician doesn't have sufficient cost measures applicable, and then they will assign a weight of 0% to the cost performance category in the final score. And if other performance categories are reweighted, the cost performance category will always be weighted to either 30 or 0%, and CMS won't redistribute weight to the cost performance category. However, in cases when the cost and improvement activities performance categories are the only two categories scored, both categories will receive a weight of 50%. Next slide, please. And here are just some resources to help and support eligible clinicians and groups. Next slide. So here are several key resources and websites, including the Quality Payment Program website and the webinar library and resource library, as well as links to sign up for the QPP listserv. Next slide. And then to get help from CMS, we recommend reaching out to the QPP Service Center, and they can be reached by both email, a ticket service, or by phone. Next slide. Great, and that's all I had today. Thanks for joining.